My name is Kate Sullivan, and I'm representing the Medical Advisory Board of the Immune Deficiency Foundation. Today is May 29th, and we are in week 12 of the COVID-19 pandemic. We just passed a tragic milestone of 100,000 deaths in the U.S. from COVID-19. It has been a long 3 months. I am going to confine my video today on just a few topics. This is meant to be very focused on people with primary immune deficiencies or inborn errors of immunity, and I'm going to tackle 3 questions that I think are quite common. I'm going to try to tackle the differences between PCR testing for COVID-19 versus antibody testing, which is now available. I'm going to talk about protection with IVIG and whether it's really important that you get extra or get it on time. And I will try to tackle the very difficult topic of back to school. And then I'm going to end with an overview of an inflammatory condition you may have heard about that is happening as people recover from COVID-19. That has been named MIS-C for Multisystem Inflammatory Syndrome of Children, and I'll talk about that at the end. So let me get started with the 3 practical questions first. What is the difference between nucleic acid testing or PCR testing and antibody testing? Technically, they are quite different. So the PCR test or nucleic acid test is actually looking for the chromosomes of the virus, usually in the sputum. It can be done on any tissue or fluid, but practically speaking, it's usually done from a swab that's in the nose, sometimes the back of the throat. And so what they're looking for is the presence of virus, and it's very sensitive. It's used for a number of different tests. It's very accurate. It will not tell you if that virus is infectious. So viruses can die, be beat up, be disabled, but their chromosomes are still floating around, and so you can still detect a virus even if it's not infectious using that test. So the PCR test or the nucleic acid test is what is being largely used diagnostically for acute testing of patients who have symptoms. The antibody test, and who knows more about antibody tests than immune deficient people, the antibody test is really looking to see, did the body make an immune response to the virus? It is less useful in the acute setting because making that antibody takes time. It's not instantaneous. It takes a week to 2 weeks and can even take a month depending on the specific part of the virus that is being surveyed for antibody production. So antibody production is not instant. It does take time. So it's not as useful diagnostically for people with symptoms. It can be quite useful for epidemiologic reasons. If you want to go into a daycare setting and say, have all of the instructors had it already? So it's useful in that setting. I will say right now, there are a lot of different antibody tests out there on the market. Some of them you can buy online yourself. They are not all equally validated, and they are not entirely the same thing. And so having one antibody test is not the same thing as another. I will say there probably are good tests that are do-it-yourself kits at home, but even amongst very reputable vendors of antibody tests, we still don't know the precise sensitivity and specificity, which means, practically speaking, there are both false negatives and false positives. Furthermore, just because you have an antibody as detected by one of these tests, it doesn't necessarily mean you're protected. Well, furthermore, immune deficient patients don't always make good antibodies. So could that test even be useful in someone who doesn't make antibody? There's quite a broad range. So even across all people who have problems with antibody production, there's still quite a broad range of capacity to make antibody to any given thing. So in common variable, for example, we know some people retain some ability to make antibodies to tetanus and some pneumococcal serotypes. So it's uncommon for someone to have no ability at all. It does happen with X-linked A gamma globulinemia, but it's uncommon for people to have zero ability to make any antibody to anything. So these antibody tests I would not encourage people to get for philosophical reasons. I'm not sure they're very helpful, but I also recognize that people that are immune deficient may not even be able to make those antibodies. So while we're on the subject of antibodies, the second question is, should I stop my immunoglobulin replacement therapy? Should I get extra? What's the role of immunoglobulin in prevention of COVID-19? So that's a common question, and there's a subtlety to it that I'm going to ignore for the moment. I'm going to start with the easiest part of the answer, which is that right now, immunoglobulin replacement products, no matter what brand you get, do not have antibodies to COVID-19. That will change over time as more people that have recovered donate plasma, but right now, that immunoglobulin replacement that you are getting doesn't offer you any additional protection specifically from COVID-19. That doesn't mean it's not a good idea to keep on schedule. It is, because of course COVID-19, as is true for any virus, represents a significant risk of bacterial infection, and that immunoglobulin replacement product will serve you very well in terms of preventing that bacterial superinfection. So I would urge you to stay on schedule. I know there's a temptation to try and say, I'm not letting anyone into my house, I'm not having any exposures, maybe I don't need it for the next few months until this whole thing burns out. I'm not sure we are a few months from seeing this burn out, and I will say the home care companies and the infusion centers have been incredibly diligent about wearing PPE and delivering nursing care in a very safe manner. So I would encourage everyone to stay on schedule if you're on immunoglobulin replacement. There was a subtlety that I alluded to, and that is the question about whether cross-reacting antibodies might provide some protection against COVID-19. So there are many other coronaviruses, and most of us have had them at some point, and those antibodies are present in immunoglobulin replacement products. Could they provide some protection? They might. If they do, it is very marginal. So getting extra doses of immunoglobulin is not likely to be beneficial. And that brings me to my third question. What about going back to school or going back to work? When can that happen? How will we know it's safe? I think as this has gone on, we have come to realize that it's not going to burn out. Maybe it will go down in the summer. Maybe it will go down because of social distancing and mask wearing. I think it's unlikely to go away, and so, meaning there's no more cases ever. So I think we have to come to terms with a much more nuanced idea of risk management. So I'm not going to give you an answer here and say, yes, you can go on October 1st, or yes, you can go in December when there's a vaccine. We don't know that the vaccine will work, and we don't know that there will be an end to this where we can say there is zero risk. And so we all have to get a lot more comfortable in looking at risk-benefit ratios that are unique for ourselves. But here are a few thoughts that I think could guide your decision to go back to work or start school in September. I think number one absolutely is community prevalence. So that means the infection rate in the moment, not New York City had the highest rate in the US and has had the most cases. Maybe in October, New York will have no cases, in which case I would feel very good about going to school. It has to be the infection rate at the moment in your community, and each community is going to be very different. And that's one of the reasons for the idea that having a lot of testing out there and contact tracing can be effective, because if you catch the one person who has it and prevent them from giving it to 100 other people, you'll keep any outbreak quite small. So I think community prevalence is the number one variable for me in deciding whether to go to work or school. Number two would be capacity for infection prevention. So in a school system, the ability, or on a sports team or in a work setting, the ability of that group that you're surrounded by to mask, social distance, do all hand wash, all the things that we know are effective. That's going to be a lot harder to pull off for a group of 2-year-olds than it is for a group of 12-year-olds or a group of 20-year-olds. So the capacity for infection prevention is my number 2 variable that I consider. And then number 3 is personal risk. So we still do not know a great deal about which immune deficiencies are associated with the highest risk of severe disease. I mentioned that there was a survey that is now published on the ESID website that you can look at, it's public, that looked at 51 immune deficient patients. Overall, I think the news was good. Antibody deficiency did not seem to be a huge risk for hospitalization and severe disease, but I think we still have a lot to learn. And in this regard, I want to point out that the Immune Deficiency Foundation has an open survey for patients to enroll themselves so that we can continue to learn about who gets severe disease and if there are specific diagnoses where that risk is higher. So please contribute to that Immune Deficiency Foundation survey. It's on the main website. So I'm going to end now, since I couldn't exactly answer back to school and I just ended up giving some guidelines. I'm going to turn my attention now to a different condition, and this has been called in the US multisystem inflammatory syndrome of children. You'll also hear it referred to as a hyperinflammatory syndrome related to COVID-19. In Europe, it's called PMIS. I will just call it a hyperinflammatory syndrome, and it happens uniquely in children, not adults, and it happens as they are recovering from COVID-19. So about a month after they've had COVID-19, they develop fever, large lymph nodes, usually quite a bit of abdominal pain and diarrhea, and they really look quite sick. One of the reasons they look so sick is that their heart is not contracting very well, so they're having trouble moving blood around. So this is quite terrifying. The good news is that to date, every single child has been previously well. There has not been any antecedent condition that suggests that having an immune deficiency would in any way set you up as having increased risk for this hyperinflammatory syndrome. It is terrifying to see. We have seen a few cases here in Philadelphia, and it is quite terrifying. I will say that the children recover very nicely, and they recover with immunoglobulin, and I think there's probably a message there. So we don't see a lot of COVID-19, or at least severe COVID-19 in children, period. And this is a rare complication of COVID-19 in children. And the reason I bring it up is it is not thought to be associated with immune deficiencies as far as we know. So I'm going to end there, and as always, I wish that you stay safe and be strong, and please think about contributing to the IDF survey on COVID-19. Take care and be well.